Welcome to Raaonline teaching. So we'll discuss about salicylate toxicity. Salicylate, literally we are going to discuss about aspirin. Aspirin is one of the most commonly used regular medications in elderly. One among in our family member could be using this, and we need to know aspirin in detail. Not only the real day practice, even long back during the time of war, people were suffering from significant tissue injury, inflammation, pain and fever, and there were no good drugs that could reduce this inflammation and pain. Only after the advent of paracetamol, some amount of fever and inflammation was taken care. But as we already know, paracetamol has very less anti-inflammatory action, that too at the periphery level. But this tissue injury was understood to be because of release of bradykinins, cytokines that increases the prostaglandins, leading to the inflammation and pain. Not only the inflammation and pain, even fever is caused by the cytokines, that is interleukin, alpha beta interferons, tumor necrosis factor alpha. Again, these increases the prostaglandin E2, that increases the cyclic AMP. This triggers the hypothalamus to increase the body temperature. So the world was actually searching for an effective drug that could decrease this inflammation and pain and fever. And that is where the birth of aspirin. Aspirin is not actually a new drug. Even at the time of Hippocrates, willow bark and leaf extract from the Salix species were used to relieve fever. But the active component from this Salix species was retrieved and made into a less irritant form, that is acetyl salicylic acid, was made only at the 19th century, that is 1899, was commercially introduced as aspirin by Mr. Bayer. So, this salicylic acid esters are of two types. One, phenolic esters, that is aspirin, and carboxylic acid esters, the methyl salicylate, phenyl salicylate, and glycosalicylate. So, these compounds had significant analgesic property, anti-inflammatory property, and antipyretic property. This basically acts by inhibiting the COX enzyme that we all know, but these medications have direct inhibitory action on neutrophils also. So what is this COX enzyme? Where does it fit in? So let's understand this. The phospholipids are there in the cell wall membranes, and when there is a direct insult to these by an inflammatory mechanism or tissue injury, phospholipase A2 gets activated. So this phospholipase A2 acts on the phospholipids at the cell wall and puts out arachidonic acid plus lysophospholipids. So this arachidonic acid is acted upon by cyclooxygenase, then gives out PGG2, which is an intermediate substrate. It is very unstable, that peroxidase acts on this and gets converted into PGH2. It has to be understood that cyclooxygenase and peroxidase are one and the same group of enzyme. This is COX1 and COX2. This belongs to domain A of COX. Peroxidase belongs to domain B of COX. Okay, COX1 and COX2 is domain A, peroxidase is domain B of the same COX enzyme. That is why arachidonic acid, though getting converted into PGG2, immediately gets converted into PGH2. Then by individual synthetases, individual PGE2, prostaglandin I2, thromboxane A2 and PGF2 alpha gets created. Adding more material to that, so this is the cell wall. When there is a bacterial injury or macrophages activation or the tissue injury or any kind of inflammatory stimulus can activate this phospholipase A2. So this acts upon the cell wall, putting out the arachidonic acid, which is acted upon by COX1 and COX2, giving to PGG2, ultimately leading to prostaglandin. So your corticosteroids is going to act at this level. Your NSAIDs along with the salicylate, the aspirin is going to act at this level, and your acetaminophen, the paracetamol, is going to act at this level. Okay. Pharmacokinetics. Aspirin, when taken orally, gets absorbed by the stomach because aspirin pKa is 3.5, but the stomach's pH, as we know, it's 1 to 2. Having significant acidity in the stomach, absorption of aspirin from the stomach is actually easy. But after the stomach, the small intestine, as we know, the pH is going to be towards alkalinity. So the absorption of aspirin in the small intestine is actually at the lower rate. But if you compare the surface area of stomach to the small intestine has a larger surface area. So the absorption of aspirin throughout the small intestine happens. So absorption of aspirin not only in the stomach but also in the small intestine is quite significant. In immediate release preparation, which is mentioned here as IRP, the therapeutic serum concentrations reaches in less than 30 minutes, peak concentration less than 1 hour, and the half-life of the salicylate is 2 hours at antiplatelet dose, and a slightly higher dose, that's anti-inflammatory dose 12 hours, and in toxic dose it is 20 hours. So once taken inside, the biotransformation of acetyl salicylic acid takes place in the liver. So acetyl salicylic acid loses the acetylation and becomes salicylic acid. So after the pathogens, it eliminated by the kidneys. We'll see this in detail. Understand one basic concept that because the platelets cannot regenerate the COX-1 enzyme, a daily dose of just 30 mg of aspirin can inhibit this COX so that that particular platelet will go dysfunctional for the rest of its lifespan, that is around 8 to 12 days. Toxicokinetics. The toxicokinetics actually depends upon the dose, formulation, rate of gastric emptying, alteration of the gastric pH by any intake of drugs like proton pump inhibitors, H2 antagonists like ranitidine or bezoar formation, hepatic and renal function, and the serum and urine pH. Remember, apart from the immediate release preparations, there are entry-coated tablets available. The peak serum concentrations for these kind of entry-coated tablets in therapeutic dosages is going to be 4 to 6 hours. In toxic doses, it's going to be 24 hours. So this tells you a clue that the GI decontamination is still a possibility in this kind of toxicity. Let's try to understand this. Either it's an acetylated salicylic acid or methyl salicylic acid.